We're going to dive right in. This is an opportunity for us to really gather and with this group to discuss exactly where the federal role might be in ways of getting smarter, being bolder, and being more integrative in thinking about just data, thinking about how we combine data across sectors, work across sectors, and work across regions. And our goal would be to leverage this data, leverage the information to protect health, preserve and promote health. And the pandemic, of course, is one of the driving factors. But as you heard from Gabriel, it is not the only reason that we should be thinking about advancing how we use data to protect, preserve, and promote health. So fortunately, our speakers this afternoon bring a tremendous amount of experience and firsthand knowledge that will help us think through this. David Brailer here is the Executive Vice President and Chief Health Officer of Cigna. David has the distinction of serving as the nation's first National Coordinator for Health Information Technology, appointed by President George W. Bush back in 2004. Then we have David Feinberg. He is the chairman of Oracle Health. Two Davids.
Two Davids, yeah.
David B. and David F. David F. is the chairman of Oracle Health, a position he comes to after a very long career in health systems leadership. And then Julie Gerberding, the CEO of the Foundation for the National Institute of Health, and she was also the former director of the Centers for Disease Control and Prevention. So without further ado, I thought we'd get right into our conversation, and I will identify, I'll direct a question to a particular person, but welcome an opportunity if you want to jump in, okay? And I'll start with you, David Brailer. Take us back to 2004, when you became the first National Coordinator for Health Information Technology, the first czar in this space. What was your vision then for how data and digital technology could be used to improve population health? And the second part of that question is, how much have we accomplished and how much more have we to do?
I have 2 hours on that. So thanks, it's great to be here. It's good to see David again, another David. So I thought it was really cool to be able to be the first national coordinator because I thought, wow, we get to draw the box that solves, tells people where the zone of play is. What I didn't realize is something that Julie knew as an established federal leader, that the best thing about being the first is I had to spend zero amount of time defending the stupid decisions of my predecessor. Never happened to you, right? So we articulated 4 priorities to have a step function increase in clinical decision-making in quality, to accelerate consumer self-care, self-empowerment, to advance clinical research and science at the bedside, and to advance public health. And underlying all those was interoperability. What is our scorecard? Advancing clinical decision-making and quality, I would say big check, high tech, push that all the way through. Some of you might have heard that there are electronic medical records around now. David, I know, clearly knows. Consumer empowerment, consumer ownership, I think it's a half check. It's still not quite there yet, but we have a robust, thriving investment community, startup, entrepreneurial community around all forms of digital touching consumers. Federal government's come along with transparency and other things. Clinical research, I think not quite a check, but I feel like there's some migration. Clearly, we've now accepted standards throughout the clinical discovery process. They are integrated at the point of care theoretically. Obviously, it's an incredibly data-driven process, but still disjoint from patient care in a way that I'm comfortable with. Public health, I would give it an absolute 0 because of the issues that we're here to talk about today. We have not made a step function change despite the potential. Interoperability underlying all that, I'm quite optimistic about. I think we're at the part of the S-curve where it starts really getting leverage. As was mentioned by Gabe, the QHIN and the TEFCA rules that are now out and the announcement of partners in 2 weeks, I think is a major milestone that we envisioned then, and it took this long to get there. So I'm optimistic, but we have an enormous amount of work to do.
Yeah, a really candid assessment of where we are, particularly the public health part of the mission. Julie, I want to turn to you. And, I earlier this month, I think just about 2 weeks ago, a group that you co-chair, the CSIS Commission on Strengthening America's Health Security, was released. And it's a major bipartisan report with recommendations for strengthening the CDC. Could you first explain some of the major challenges the CDC faces in using data to serve public health, and outline some of the key recommendations that you and your colleagues have put forth?
Thank you, and it is an honor to participate in this frontier conversation, so thank you for including me. The report was really, in a sense, a crisis report. It was recognizing that the CDC is in great peril right now from a political and a trust perspective. So the report was not designed to be the roadmap for a reinvented or modernized CDC public health system. It was really meant to define what can be done in the near term to solve some of the most immediate and pressing problems. And those problems include some performance issues inside of the CDC, for sure. We're all aware of the testing issues and so forth. Issues around acquisition, interpretation, utilization, timeliness, completeness, and reliability of data as a very major theme across there. And then the broader issue of politicalization and trust, and in the context of a society that has become increasingly polarized and that trust in science has declined so much. So it was kind of a perfect storm for the CDC to really lose a great deal of credibility. And I think, germane to our conversation today about data, I was asked to write an editorial somewhere in the middle of the first year of the pandemic, trying to explain why it took so long for CDC to understand the mortality rate from COVID. And so that means looking at vital statistics information. And, I get it. Like, how hard could it be to determine whether someone's dead or alive? And, this should not be a challenging algorithm. But in fact, it really displays the challenge that is a microcosm of the whole problem. Local data matter most. And at the local level, usually the funeral directors are pretty good about completing their part of the death certificate. Doctors are not. Health systems no longer pay for the people called nosologists who used to accurately complete death certificates. Even if the local health department or the local jurisdiction gets the certificate completed, it goes usually to at least the state, where the state processes and reviews it. Some states are still faxing death certificate information to the CDC. They are so notoriously inaccurate that about 20% of the time CDC has to manually inspect, recode, call, get more information, et cetera. All of this takes an enormous amount of time. And in the context of a pandemic, it was clearly a choke point in the system. So that's just one example of one piece of information that everyone was clamoring to have in real time, but was not available anywhere near real time, and probably still is a struggle, I'm guessing. It also just reveals the problem of infrastructure at the local level, at the state level, and certainly at the CDC level. The investment in just vital statistics in 2020 is far less on a per capita basis than it was in 1960. So you can kind of get a sense that we're just not making the appropriate investments in maintaining modern and let alone state-of-the-art data systems. So what the report really called for was obviously data modernization that would address some of the checkpoints. Clearly, budget is a big piece of that. I think we heard this morning that the LA County budget for data modernization over 5 years is $8 million. Like, that's pixie dust. But in addition, the budget that is available is not flexible. For the CDC, they have 160 budget lines, 13 treasury accounts, no capacity to move dollars from one budget line to another, and basically no contract flexibility or the ability to do anything fast in an emergency. So should they want to surge to be able to have support for data collection, they have to go to the CDC Foundation, raise money through the foundation to be able to hire the 3,000 people that were deployed to help out at the state and local level. This is not a formula for success. And the last piece, I think, in the report was really a recognition that we don't have the workforce. That's a huge choke point. We don't have the workforce deployed to the front line where it's needed the most to really help build out the more modern systems locally. And then broadly speaking, not really focused in the report, but certainly a topic of conversation was the whole sociology of data. The data are power, data are proprietary, data are prosperity to some people who make money off of them. Data are private, and that creates all of these barriers to sharing information in the health space. And ultimately, the disincentives to make data readily available for action in many cases outweigh the incentives and certainly the resources to do that effectively. So the report does call for, obviously, more investment, for Congress to take some actions to improve the authorities around data acquisition and sharing, but also to invest more in the data modernization effort, and certainly to extend the reach and the capacity of trained public health officials by embedding them locally and in the states to be able to bring an exchange of information and expertise and hopefully help shore up. But as I said, these are all crisis interventions, things that can be done now. These are not the long-term solutions that you envisioned for population health when you were the czar. And I think we still have a lot of opportunity here to think differently about how we approach population health data systems.
Julie, I'm going to follow up with a question. You lay out a roadmap for how we can improve the data systems for public health. Do you see any hint that there's realization that this is an investment that will return manyfold over the cost of creating an operable public health data system?
By looking outside of the United States, the answer has to be yes, because there are examples where this has happened in other jurisdictions, other countries. We have a big challenge here in being a federation of states, and there is still no authority to mandate data reporting even in a public health emergency. So we have to go through a very complicated and onerous process to be able to exchange and share information outside of a jurisdiction, and that is a major choke point which hasn't been overcome. I am not sure how we're going to get past that one, so it's hard for me to be optimistic. Just to give you concrete, in COVID, it took 3 months to get a waiver from the OMB to get around the Paper Reduction Act that requires you to go out and get public content anytime you put out a new request for information for data. So 3 months in a pandemic to get a waiver so that CDC could send forms out to collect data. I think we've got a lot of work to do.
Yeah. Culture change is hard.
Government is harder.
Government is harder, but the technology alone won't get us where we need to go, and I think that's a really important part of the message. We'll come back. David Feinberg, Oracle Health is a huge provider of healthcare technology. You partner with insurers and healthcare systems, and you also partner with public agencies, really at that intersection of public and private partnership for the U.S. and abroad. I'd love to get your take on how private tech companies such as Oracle can partner with the federal government to address some of the challenges that Julie and David outlined.
Yeah, well, I'd also like to point out I had 7 Davids in my second grade class, so I'm very comfortable with this setup. Yeah, and happy to be here. What we're trying to do, and it's pretty ambitious, is different than what I think some other tech companies have tried before. And I think what other tech companies have done, I think maybe this is too severe, but 2 mistakes they made that we're trying to avoid. One was point solutions, coming in and fixing one thing in healthcare. And for those of us that have spent our career in healthcare, this is a complicated ecosystem that has so many pressures that those point systems, solutions, albeit fantastic, oftentimes there's so many antibodies to any change they get kicked out. So we're trying to do it instead of a point solution, completely go end to end and change the whole platform. Now you could say that's way too ambitious, but that's the going in space. And then the other thing we're trying to do differently is not be jerks. And I think that tech companies often come in and think that those of us in healthcare are stupid. And if we just use this app, everything would get better. Because look, we did it in shopping, we did it in retail, we've done it in finance, we've done it in travel. Like, why haven't you dummies figured this out?
Yeah.
And I'm obviously exaggerating, but or maybe I'm not, but what we're trying to do is come in and be humble and inquisitive and do it from the inside out. So Cerner, which Oracle purchased about a year ago, is the largest EHR company in the world by a significant margin, so from a market share. And what I would say to the team is that means we have more grandma's blood sugar than anyone else. And when you have grandma's blood sugar, you got to keep it safe. It's got to be secure. It's actually really important that we understand, does grandma have food? And what about the rest of the family and the community where grandma resides? That's what that means. So with Oracle jumping in the water, not putting a toe in the water, by bringing Oracle into the fold, it is a pretty big move for a tech company. And so we're trying to build a platform, cloud-enabled, that brings together, and it was a lot of the things David talked about. Oracle Financial Services is a vertical that processes, it has two parts of it. 80% of the world's credit cards run on Oracle software. The other part of Oracle Financial Services is claims processing, right? So what if we bring claims processing together with clinical information to do auto adjudication for 99% of encounters? So you never get one of those stupid EOBs again, but literally, we're that trusted intermediary. David also brought up clinical trials. So Oracle has done a lot of work in software for pharma companies. And we can really use real world evidence that we have on the EHR side so that we build infrastructure to small communities and close the gap in research that is just, we know is biased because we haven't brought the right people in. Our Learning Health Network has 3 times the rate of diversity of any clinical trial network out there. So we've really built that in as infrastructure. And then combining the electronic health record with things like, and this may not seem particularly sexy, but combining it with human capital management. So when the nurse is giving chemo for the very first time, we should know that. And just-in-time training, because we know the nurse, should happen in the EHR. And none of this will work if we don't build our systems that are actually user-friendly. When you talk about this thing that we do, healthcare technology, to people in technology that aren't in healthcare, I like to point out we're the only software that we had to pay people to use. Like in every other business, they wanted the software. Ours is so bad, we had to pay people to use it. So if we could actually get the usability right, and now all of a sudden, instead of saying to a primary care doctor, you have so many more clicks to do, but rather we understand what you're doing and we can help you get through your day faster. And it's intuitive, and we can use voice, and we can use things that you use in the rest of your world in a tech standpoint in your workflow. We're gonna get this amazing opportunity. Now, I don't wanna beat up on tech completely. Nobody during COVID in the United States went into the ER and the ER said, we can't find your chart because Dr. Brailer took it home over the weekend. And no one during COVID said, I can't read this doctor's prescription. So we fixed digital, we fixed the prescription issue, the records, and the interoperability, to me, and I'm very optimistic also, I think is fixed, but it creates more problems. So when you look at somebody now treating a patient, a hospitalist, I'm new this week, I got all new patients. We have these health information exchanges that have the data, but you're looking at 40 or 50 PDFs of records. You can't find the information. So it's there, it's flowing. It's just giving needles and haystacks. We have a product that's coming out that takes all of the information on a patient from outside records, puts it into a longitudinal format, and then we thought, well, we should deduplicate it because there's probably duplicate information. For me, it says many times when I had my skin biopsy, when my colonoscopy was. It turns out medications, laboratories, radiology, prognosis notes, 99% of information is duplicate. So we're saying to clinicians, here's all the information from an interoperability standpoint, but it's not what they're looking for. They've seen this information. So we deduplicate it and then bring it to you at the time you need it. So when I'm doing medications, show me the one new medication that I don't see. Yeah. So there's work to do, but I do believe we have the digital framework now to try to create a different way of delivering care that's more equitable, that's higher quality, and dramatically less costly.
You mentioned having grandma's blood sugars. Do you also have that she's living in a food desert? That, she's house insecure? I'm asking this because, the clinical data system without the social determinants doesn't give one the full picture of what the clinicians are treating.
So we have all of that information, and there's others that have it. And sometimes it's by zip code, and sometimes it's by block, and it's not perfect, but it's definitely close enough to take care of grandma. The issue becomes, if you tell a clinician, go log over here to get that information, a primary care doctor today, if you tell them, do everything you're supposed to do for your patients, they could complete their day in 27 hours. And then if you say, I'll give you a bunch of nurse practitioners and physician assistants to help you, now they can get their day done in 13 hours. So you literally can't get your day done. So if it's not built in the workflow, it doesn't happen. So that data's out there, we have it. The key is getting in the workflow. And when you really talk about burnout, the concept of burnout didn't come because of pajama time of people working in EHRs in the evening, although that is a driver. The burnout came because you saw the drug addict with IV drug abuse that came in with a heart valve that was infected, and you treated them for 3 weeks with antibiotics. You sent them out, and 2 weeks later they came back. There was this moral hazard of, wow, I'm doing the same thing over and over. So not only do we have to get the social determinant information in the workflow so you understand grandma doesn't have transportation, but you have to make it really easy. You actually have to take away work to get grandma the transportation, right? So the effector arm to make sure that there's safe housing and food. And we did it when I was at Geisinger. We had, we'd serve 5 million meals a year to type 2 diabetics that were food insecure, and saw quinoa and kale is better than metformin, and it drives down healthcare costs and the rest of the family gets healthy. But it's gotta be in the workflow. So that to me is a very important piece. Yes, we do have the data, and we work really hard to make it make it easier for you to get those interventions.
Thank you. David Brailer, I want to come back to you. The nation's environment for health data is currently a patchwork. There's some interesting and nice models, but nationally it's really still a patchwork with many different regulations and systems between government and the state, federal government and the state. What do you see as the next steps for federal leadership to harmonize this patchwork, and how can states contribute to this harmonization aspiration?
I assume the context of your question is around public health, although I think it's clearly part of an ecosystem, but I'll speak to that. If you go back to I think it's June 2004 testimony I gave before the House Ways and Means Committee, Pete Stark sitting right there, I said I was pretty certain that the first landfall of significant data progress would be in public health. And the reason for that, and I think the reason is incredibly relevant today, was that one of the first tasks that I did when I got there was studied the implementation of Index. Index, which I know you know about because you were in the middle of, Index was the result of 9/11, where it was pretty clear that the national security agencies, FBI, et cetera, were unable to track even flagged terrorists because they were pulled over for a speeding ticket or they had some other infraction and completely unable to understand what was going on across the national law enforcement sphere. An index, which stood for National Data Exchange, the fact they called it that showed you how few other data exchanges there were at the time, which is still current and has been modernized twice, at least twice, major rehabs, created a multi-jurisdictional system that included standards, data content, reporting requirements, and interchange agreements between jurisdictions, state, local, federal, tribal, territorial, so that the data could be assimilated and used at each level based on permissible uses of that kind of data. And it had three characteristics. One, it came about as a result of top-down federal funding, which came about because of a determination that there was an important strategic need for the U.S. from a defense posture. We all remember that. Two, the alignment of jurisdictions across that participation, because they didn't get their share of the money if they didn't participate, and their share of the money paid for the modernization of their local infrastructure, et cetera. And third, a requirement that the private sector participated as well. So if you were a local security company and you did contracting work, you had to at least be able to report data. I made that comment to Ways and Means because I said, this is the formula for public health. It's the same multi-jurisdictional challenges. It's the same lack of funding infrastructure. And my big mistake was, it's the same strategic need. And I think what we have not done today, we didn't do then, because it failed miserably. We walked this around, committee after committee, OMB, the White House, nobody would bite on it. They all agreed it was important, no question about it, but you want $3.9 billion to pull this off, Brailer? Like, it's not going to happen. And it was even technically demonstrated. What we needed to do, the data payloads were quite different, but the way they were used and the amalgamations and the cross and up and down reporting and the assimilations were almost like right out of the same book. People did not understand why it was helpful to the nation. And I think today we have that same challenge. Index and all of its siblings, because there are about 12 major platforms that are built in this infrastructure now, are still right next to our failure of data in public health, a living example of exactly how it works in America, and it works beautifully. And yet people today, I think, do not understand why that is helpful, because I don't think they understand what's going on with all the failures that we live with and deal with and try to overcome within public health itself.
That leads into my lightning question, and I think we have 3 minutes, so you each have 1 minute. In light of David's response, what is your best pitch, your best elevator pitch to the public and maybe the electeds for why there is a compelling reason for investing in creating a data structure that really helps in the space of public health and healthcare? I want to start with you, David Feinberg.
Well, I'll give the pitch. I'm not telling you that this is what I think is the right one. I just think it's a pitch that may win. So when you look around our country, you just got to go a couple subway stops and see life expectancy changes 25 years.
Yeah.
And we've now shown that everywhere. And so when you talk to the Walmarts of the world that serve all Americans, but predominantly poor and rural, and I'll just use them as an example, they can try to compete with Amazon on shipping and all that kind of stuff. Or they can actually increase their business and their revenue future by closing that gap of a bunch of people dying. And if those people live longer, they'll buy more toilet paper and soda and whatever else, and some stuff they shouldn't even be buying. But I think you have to, in this country, make a business case that says keeping people healthy is actually really, really good for the economy. And the private sector needs to then come in. And you've seen it before where the private sector, did wellness programs, it'll keep my workers healthy. I think it's got to be a little more compelling. But to me, the pitch would be, hey, this is good for business if we take these people that are on the wrong side of the tracks and give them healthy food, a sense of purpose, housing, dignity. It's actually good business.
Yeah, appeal to enlightened self-interest.
There you go. There you go.
Julie, your pitch.
I don't really have an answer to this. I think, my grandmother's always been my mental model of the public. So what would convince my grandmother, who's no longer with us, but she, and I think it has to do with kids and the fact that, every adult, every parent, every grandparent wants to make sure that their children can have the best possible life and the longest possible healthy life, and that we can't do that without really making knowledge out of the data that we have and using it to find actions that can truly ameliorate the lack of progress that we've seen in the last decade and hopefully get us back on track so that we can be the healthiest nation.
It's pretty good for a non-answer.
Yeah.
My grandmother has all the answers.
So David B., you get the last word. Your pitch.
So in 2005, Health IT was on a roll in DC. We were really just getting a lot of support. We were, remember that? And I was in the metro and it was sitting there and I looked across, the metro car, and there was a poster. It's one of those like, this is your brain on drugs. Remember those? And it was like sponsored by the Ad Council. And I looked at that and I have to admit I was absolutely furious, because I went back to my chief of staff and said, I want posters like that about Health IT in the subway. And we convened the Ad Council, and after 3 months of this, this pro bono work, they came back and said, we cannot think of a way to sell this to the American public. I think the best we got was a ladder and a guy falling off, and the caption was, will your data be there? But I think the sales pitch is for public health, not for public health data.
Yeah. But we also need good PR.
We do.
We really
tell
need
the
good
story.
PR. We got to tell the story.
Got to tell the story.
Yeah, and appeal to self-interest.
There you go.
Well, listen, we are at our time. Thank you, everybody, for participating in this. And now I'm going to turn it over to Dr. David Agus.